Physical examination of the respiratory system. Part 1. This is lecture outline. Aim and objectives. At the end of the lecture, the students are expected to know physical examination of the respiratory system. Objectives include correct method of examination, interpretation of physical signs, able to correlate with the underlying pathology. Lecture contents. 1. Introduce, positioning, and exposure of the patient. 3. Examination of the anterior part of the chest, followed by the posterior, which includes inspection, palpation, percussion, and auscultation. 3. Expected physical signs based on the underlying pathology. This is reference textbook, McLeod-Klinger Examination, 14th edition, 2018. The physical examination. Before starting examination, 1. Wash your hands with antiseptic solution provided. 2. Introduce with your name and role. 3. Get the verbal consent of the patient. 4. Chaperone if necessary. And 5. Draw the curtain. Positioning the patient. Lying on the couch or bed at about 45-degree inclination. 1. Inspection. First, inspect from the end of the bed. Later, if necessary, inspect the lateral and back of the chest. Note whether patient is in respiratory distress. Check the accessory muscles of the neck, whether they are in action. And type of the breathing, whether it is pursed-lip breathing, including position of the patient, tripod position. These all you will see in advanced stage of COPD. Examination of the respiratory system. First, note the presence of nebulizers, inhalers, oxygen therapy, and sputum pots. Shape of the chest wall from inspection. Normally, the shape of the chest wall is bilateral symmetrical. Transverse diameter is more than the antero-posterior diameter, that is elliptical in shape. In chronic obstructive pulmonary disease, commonly antero-posterior diameter is equal or more than the transverse diameter, that is barrel chest. Other congenital deformities. 1. Kyphoscoliosis. In this condition, there is exaggerated lateral and forward curvature of the spine. 2. Pectus carinatum. Part of the sternum or the whole sternum becoming prominent, with or without prominent Harrison sulcus. Pigeon chest. 3. pectus excavatum. Part or the whole sternum is depressed. Funnel chest. Quad D. Observe the respiratory rate without drawing the patient's attention to it. For that, what you can do is feel the radial pulse while timing the breathing. For example, breaths in 15 seconds times 4 will tell you how much is the patient's respiratory rate in 1 minute. At the same time, note any operative scars from lung surgery or chest drains. The rest, skin nodules, maybe secondary metastasis or dilated veins over the chest due to superior vena cava obstruction. Additional findings are puffy and plethoric face, raised GVP, that is internal jugular vein, but no pulsation. Dilated veins with the blood flow from above downwards. Sometimes in patients with a thin chest wall, as in exacerbation of asthma or COPD. You can see enrollment of the skin in the intercostal spaces during inspiration, that is intercostal recession.